Colorectal carcinoma. Colorectal carcinoma, also known as colon cancer, is influenced by various risk factors. These include familial polyposis coli, hereditary non-polyposis colorectal cancer, HNPCC or Lynch syndrome, inflammatory bowel disease, particularly ulcerative colitis and Crohn's disease. Adenomatous polyposis, smoking, alcohol consumption, and dietary factors such as red meat and a high-fat diet. The clinical features of colorectal carcinoma are diverse. Rectum, rectosigmoid, is the most commonly affected site. Tumors in the cecum and hepatic flexure may form palpable masses that are firm to hard, irregular in shape, and may or may not be fixed. Anemia is a significant characteristic of cecum carcinomas, resulting from either blood loss or the tumor secretion of toxins that suppress bone marrow function. Patients with colorectal carcinoma often experience symptoms such as asthenia, weakness, anorexia, dull aching abdominal pain, altered bowel habits, and intestinal obstruction. Metastasis to the liver occurs in approximately 5 to 10% of cases. Differentiating between right and left colonic carcinoma is important. Right colon cancer typically presents with unexplained weakness, anemia, occult blood and stools, and abdominal discomfort on the right side, often accompanied by dyspeptic symptoms. It is more common in women and accounts for about 10 to 20% of cases. Pathologically, right-sided tumors often exhibit ulcerative or proliferative lesions, which can be diagnosed using colonoscopy. Complications such as obstruction is less common in right colon cancer. In contrast, left colon cancer is characterized by changes in bowel habits, gross blood and stools, abdominal discomfort leading to constipation and obstruction, and a higher incidence in men. It accounts for approximately 60 to 70% of cases, including rectal cancer. Pathologically, strictures are common in the rectosigmoid region. Diagnosis is typically achieved through flexible sigmoidoscopy. Complications such as obstruction, perforation, and pericolic abscess are more frequently observed in left colon cancer. The staging of colorectal carcinoma follows Duke's classification system. Stage A indicates invasion of the muscularis propria without breaching it, while Stage B signifies breach of the muscularis propria without lymph node involvement. Stage C indicates the involvement of lymph nodes. Asfa-Collar's modification of Duke's staging further refines Stage 2 tumors as follows. Stage A, limited to the mucosa without involvement of lymph nodes. Stage B1, extension into the muscularis propria without involvement of lymph nodes. Stage B2, extension into the entire bowel wall without involvement of lymph nodes. Stage B3, extension into adjacent organs without involvement of lymph nodes. Stage C1, extension into the muscularis propria with positive lymph nodes. Stage C2, B2 stage with lymph node involvement. Stage C3, B3 stage with lymph node involvement. Stage D, presence of distant metastasis. Screening should be offered to all individuals, both men and women, between the ages of 60 and 74 years. Screening methods commonly used include the fecal immunochemical test, FIT, and the fecal occult blood test, FOBT. If the screening results are abnormal, patients should be offered a colonoscopy for further evaluation. Diagnosis of colorectal carcinoma. Colonoscopy is the preferred diagnostic investigation for colorectal carcinoma. Additionally, the tumor marker carcinoembryonic antigen, CEA, can be used as an adjunct in the diagnostic process. Treatment options. The treatment options for colorectal carcinoma include surgery, chemotherapy, and radiotherapy, mainly used for rectal cancer. Surgical management. 1. Carcinoma in the right colon, including the cecum. If the tumor is operable, the recommended treatment is right radical hemicolectomy. This procedure involves the removal of the terminal 6 to 8 cm of the ileum, the cecum, appendix, ascending colon, and 1/3 of the transverse colon. 2. Carcinoma in the transverse colon. VIV resection is performed, where the area supplied by the middle colic artery is removed, followed by an end-to-end anastomosis. In cases where the lesion is located at the hepatic flexure or in the transverse colon, an extended right hemicolectomy should be performed. Three. Carcinoma in the left colon. Left radical hemicolectomy is the surgical management for tumors in this area. It involves the removal of the left half of the transverse colon and the descending colon, followed by an anastomosis of the transverse colon to the sigmoid colon. 4. Carcinoma in the sigmoid colon. Radical sigmoid colectomy is performed, followed by an anastomosis of the descending colon to the rectum, colorectal anastomosis. 5. Carcinoma in the upper rectum. Anterior resection with total mesorectal excision, TME, is performed, followed by Colorado colon anastomosis. 6. Carcinoma in the lower rectum. Anterior resection with low TME is carried out, followed by Colorado rectal anastomosis. 7. Carcinoma at the anal verge. Abdominoperineal excision of the rectum is the preferred surgical approach in this case. Thank you for watching. Like and subscribe to the channel. See you in the next video.